Hello, this is Joseph Miles, and this is my project proposal for depression screening and awareness in primary care. I will start out with a review of the societal impact of depression, and I'll make a case for introducing a simple computer-aided screening tool for depression in primary care. First, some numbers on depression from the World Health Organization. They list depression as the leading cause of disability worldwide, and they attribute approximately 800,000 total deaths annually to suicide, which can be a consequence of depression. And suicide is the second leading cause of death in people 15 to 29 years old. Depression is untreated in half of all affected people by their estimation. Um, and depression being a very treatable disease, that's a staggering number that half the people out there that could be treated are just slipping through the cracks. Um, how they plan on addressing this, they want to promote public awareness of the impact of depression. They want to tackle that stigma that might keep somebody away from treatment because they don't want to be labeled as a mental patient or some other misconception that they might have about depression. And they want to empower people to get out there and utilize the health services that exist. And there actually are a bunch online as well. So some people can get care from their own home if they so choose, and I'll talk about that briefly later on in the presentation. Um, from their numbers, they believe that 2 of 3 people with depression will present to a primary care physician instead of a mental health physician or other specialist. So that's a good place that a lot of people can be caught. Um, More interesting numbers behind this: $23 billion estimated lost work days, the value of that per year, $43 billion in medical costs per year for depression. And then the study by Hafen, they report that it could be as many as $83 billion in total costs when you think about the impact that it has on other disease states and just the overall condition of patients with depression. Another interesting money motivator from the standpoint of providers is the fact that it has been suggested in 2015, a letter from LARIC, that managing depression may become part of the Medicare star rating system. That's a big catchphrase for doctors and pharmacies. The star ratings helps dictate the future reimbursement that the provider is going to get. So ears perk up when you start talking about star ratings. A few of the studies that I looked at, you'll see at the end there are lots of references. These are just selected information. Palacios and Associates, Depression and Cardiovascular Disease Equal Premature Death. All of these studies, they screened for depression, treated the depression, and found improvement in disease state and depression. Hafen, again, the 2007 study, they report a 4.5 time elevation in patients that suffer heart attack when they also have depression. So heart disease and depression is a bad combination with measured outcomes. Pibernik and Okanovich, that's a person, Pibernik, Okanovich, and Associates, 2015, they looked at diabetic patients, and what was interesting in this study is that once they identified the depression, and they had a more aggressive treatment side of the study and one that was a more laid-back observation, and they saw similar improvement in both of their groups. So even with minimal clinician interaction, they saw improvements in depression symptoms as well as diabetic condition. And just a little piece of information that sort of comes back as you review the literature on depression is that it's a very cyclical problem, that you have depression that leads to dysfunction, lost work days, troubles in interpersonal relationships, and then a life situation gets worsened by the consequences of missing work and not being able to deal with people which then leads to an increase in depression symptoms, which will further increase dysfunction, and round it can go. So why do we need to increase our awareness of depression when we are aware of it and we see advertisements for treating depression on everywhere you look? But we still need increased awareness, absolutely. Healthy People 2020 is a major goal for them to do better management of depression, and specifically they are looking at suicide as well and decreasing suicide incidents in the United States. The United States Preventive Services Task Force, USPSTF, has come right out and blanket said that anybody that is over the age of 17 should be screened for depression. No conditions on that, not people that we think should be. They think that all people should be screened. They don't specify how frequently they should be screened or what method for screening. They just want to see that it gets done. Awareness and screening equals identifying some of those 50% of the people that aren't having their depression managed and diagnosed. Depression in general, the take home here is that it's a poor prognosticator for everything. Anyone dealing with any chronic illness, we've specifically singled out heart disease and diabetes. There are many, many other studies that show poor condition in many chronic conditions. But for this, we'll stay with those. So the hypothesis of my proposed project is to initiate a computer-aided screening examination in primary care physicians, and it will help identify previously undiagnosed cases of depression. So utilizing a simple yet effective computer program will assist accurate depression diagnosis. The computer program can decrease the workload on the primary care physician and the staff. By using the computer interface, you can have patients do the test in the waiting room on a tablet type device that they could offer to them, or depending on the situation, this something that could be extended even to home. Not so much with a study, because you want to have a better observation of what's going on, but if it turns out to be a good process, you could have people do this before they even go to the doctor's office. The goal through the hypothesis is to show a statistically significant increase in depression diagnosis compared to usual care control group. What's interesting by looking at this is that my proposal does not take into account treatment, and that's on purpose. We're trying to get some numbers that seemingly don't exist from the review that I've done to show that screening for depression does increase that diagnosis and gets people into care, and the assumption here is that once they're diagnosed, they would get the care that a patient normally would get through their primary care physician. So the screening program, which I did write it to have a prototype out there, and this is a screenshot. I have it up on the Oswego computers, so you could go and play around with this. It's just a prototype, doesn't save any data or anything on there. Something to play with. The color scheme on here, the blues will get you to the next level. If you say no, basically the consent form will kick you out and tell you that you're not suitable. So just basically for prototype reasons, I have the colors to show the happy path there. The screener exam itself is the patient health questionnaire, and that is freely distributed by Pfizer. So the overall implementation cost would be low to no cost at all, depending on what sort of technology would need to be added to the doctor. Most doctors' offices have computer systems already, so it's possible that it could have no cost at all to implement something like this. The program that I wrote to run this is written in the Python language, and since it is a fully functioning computer language, it's scalable to any size. It's easy to implement that into other software. Very easy to change and adapt to the purposes that we need. And as you can see, when I switch over to the other screen, this is online, so you can do it through a web page and do it on any web browser on any computer. Could be that simple as far as implementation goes. And down the bottom of the slide, there's the web address where you can find that screening exam. The patient health questionnaire has a 2-question version that is 97.6% sensitive for screening for major depression. That's pretty awesome numbers. That's the very few people with depression are going to slip through the cracks from just these 2 questions. So it's possible when patients are taking this exam, they might only need to take these 2 questions. If they say no to both of these, they're not the happy path. You can see here I use blue because that will end the exam. It'll tell them, thank you for taking the exam, you're done. You answer yes on one of those that I have colored red for this purpose, and it will take them to the next screen. The authors mentioned here, Kroenke, Spitzer, and Williams, they are the ones that their names are tied to anything that has to do with the patient health questionnaire and its use for depression. Those 3 names keep popping back up. So this is the initial gateway. Saying yes to one of those 2 takes you to this screen here. The 9 questions. The 2 questions from PHQ-2 are here. Just the answers are more fleshed out, and each answer has a different value. I chose not to put the values on this specific version of the test, just have the wording of not at all, several days, more than half the days, nearly every day. And what's interesting about adding this 9-question version is now we've added specificity to the screening. So now we're making sure that the no's mean no as far as the outcomes of this. So overall, between the 2, we'll have strong specificity and very strong sensitivity. The reading of that PHQ-9, as I said, there's a score behind each question from 0 to 3, and there are 9 questions, so overall it can be 0 to 27, and it follows the table that you see there. Of note, a lot of the studies use 10 as their basically their break-off point, where somebody 10 or higher, basically from their standpoint, has depression, and that's the person that they're going to treat. And based on what I've read and how I've designed this, the doctor would get all of these breakdowns, and I would have them. I would suggest to them to do additional screening for people even in the 5 to 9 group. There are many screening tests for depression, but the proposed method for depression screening by Medicare is that PHQ-9. So this is back to the star ratings that I mentioned in one of the first slides. Like I said, big catchphrase here, and part of that star ratings is the PHQ-9. So a test like this would be absolutely essential if Medicare does decide to implement this. And how they implement it, or how they're considering implementing it, is to have all patients take that PHQ-9 test that I just showed. If they get a score, say, of 10 on that exam, the doctor then has to treat the patients in however they decide is the best treatment for them. But what they have to show for Medicare and Medicaid's purposes is that after 6 months of intervention, that patient needs to have a 50% reduction in their PHQ-9 score. So success is deemed by the proposed numbers to be 5 or lower in that particular patient. The steps to getting this study out and running would be to take that screening test that I've created and make it fully functioning. It is a functioning test, but go through, change the colors, so it's not red and blue, not lead patients one way or the other. Um, but the consent form does need to be fleshed out. The um, screen for pregnancy, patients 18 or under the age of 18, and both of those cases are just because the complications in those patient groups, um, especially with postpartum depression, um, in evaluation of this type in a study format is probably not the best best use of care for those patients. So they should be excluded from this. And because it's a new depression diagnosis, screening for people that have previously been diagnosed or are getting treated for depression, include that in there just as a extra stopgap. We would like to collect patient information as well that hasn't been decided um, in the tool that I've created here, but important information that we would want to look at is age, gender, possibly race, marital status. There are several others, especially from previous studies, that produce interesting information um, comparing different demographic groups against each other. I'd say most specifically gender um, seems to um, produce a lot of differing results, um, especially suicide in males is a big problem. Um, and because comorbid conditions are affected so much by depression, and maybe it goes both ways, that the chronic condition leads to depression, information we would like to flesh out a little bit better and look for heart disease and diabetes, as previously mentioned, and as well as other high-profile comorbid conditions. We would need to get primary care physicians involved so that we could use their locations. I would suggest that at least 4 locations. Four is my magic number here, and the at least is especially for the number of patients per location. There's a high dropout rate for patients in studies like this, so I would be comfortable with a number much greater than 150 if possible. In order to get this study to work correctly, of course, you've got to have the staff in the doctor's office on board and make sure that they know how to run the program, um, the assessment program, and for the most part, that should be basically here's the program, answer the questions. And then some sort of randomization needs to be set up. So a group A and a group B. Group A will immediately take the screening exam. Group B would be a control group that we would label intend to screen, so the doctor knows that they're not falling through the cracks. So as in the design of this study, this is the type of score that a patient would take when this is the type of response that a patient would get if they took the exam and they got a 5. And so it comes out and tells the patient what that number means, possibility of mild case of depression, and also tells them that information is forwarded to their doctor, Dr. Easter Bunny. At the 3-month follow-up, all Group A patients would be reassessed. Again, that's all Group A patients. See if we find more new diagnosis in the same patient group, and also to assess if the people that were diagnosed as depressed by the primary care physician in the first place, to see if their conditions were improved at all under just normal care. Again, the type of treatment is not an emphasis of this. They will get normal care from the primary care physicians at estimation of what needs to happen. Group B patients at that 3-month follow-up will take the screening test, and then there will be a 6-month follow-up. So 3 months after that, 6 months from day 0. And at that last follow-up, we would previously have established a qualitative evaluation of how well the patients thought the exam was, how easy it was to use, if it seemed to help them at all, get as much useful qualitative data from them, and especially from the primary care staff's point of view, to see if it was an interruption to their normal workflow, um, and so everybody involved in the study get a little bit of feedback and see how things get better. And again, as I mentioned before, patient retention studies like this is very difficult. So it would be interesting to see, from the standpoint of this test is one of the things that we were trying to promote in this is that it's a test that's easy to implement and can be as few as 2 questions. And so hopefully patients wouldn't be bothered by that. Again, patient's not at the focus, but here are the references down the bottom there to a bunch of different studies evaluating different online tools and showing pretty good results and improvement in depression symptoms for patients that use some of these online systems. A couple of them specifically named there. But in general, one of the goals of a study like this is increasing awareness of depression, and so this could be part of the education of the primary care physician that these things exist and are a possible tool for them to use. Again, with sensitivity, 97.6 is an awesome number, but keep in mind that that means 24 out of 1,000 patients are falling through the cracks. The take home there, and for me in general, is that I believe a computerized system like this is a nice value-added option that helps a clinician diagnose, but is not the end-all be-all. Only missing 24 patients is awesome and would be great, but would be even better if the doctor catches some of those 24. So it's not the intent to ever replace a human with a computer, and any of my suggestions, I see the computer as just adding so much more value to a patient's level of care. Toms and Ziegelstein had a study that they, more of an evaluation I should say, that they aren't as comfortable with the universal suggestion to screen all patients, and their information is good information, just basically says that we don't have studies out there that exist that show good results, and the studies that exist are looking at treatment, and as I mentioned earlier, some of the studies, even in the control groups, they're showing statistically significant depression improvement, even with limited intervention from the doctor. So I think in order to really get that information to defend the use of depression screening in primary care, you need to run a study like this. It just doesn't exist. That information doesn't show that, well, we do this screening test and we find this many more patients that are now getting treated, it will be improved, and we'll cut into that potential $83 billion that could be lost on an annual basis due to depression. The possibility of type 2 error in this type of project I see as pretty significant, because the primary care physician is hyper aware of depression symptoms, part of the education side of this and awareness of depression, that regardless of the screening tool, I could see clinicians being much more likely to have new depression diagnosis, even in the group B patients that aren't initially getting that screening test. The hope is that by labeling that group B intend to screen, hopefully it keeps that radar more towards a normal, usual care effort for diagnosing the depression in the group B. But I have a feeling that even with that type of safeguard, that there'll probably be an uptick in both groups, but it'd be hard to prove what that uptick is in group B. So in conclusion, in a nutshell, we're striving to prove that universal screening for depression in primary care can be implemented as a value-added service with only minor interruptions to standard care, and I chose to bring back from the original slide from WHO. We need to promote public awareness of the impact of depression. We need to tackle the stigma that depression is not something that um, somebody should be embarrassed about. It's something that there are real treatments for and effective treatments for, and we need to empower people to seek out those depression treatments. So when all is said and done, our total score on the PHQ-9 will be a 0, and that means very low chance of depression, and our Dr. Peter Rabbit will be happy with the end results. So at the end of this, I have a few slides of references that I will post along with this. These are the references that went behind all of the research done for this, and not all these studies were specifically mentioned in this particular presentation, but they're for anybody to review should you feel so inclined. So thank you for your attention, and have a great day.